Thank you. And I'm starting off the session on an ominous note because I'm neither a donor nor a normative agency. But I'd like to talk about how we reach universal coverage. And I think the cliff notes to this talk is, what are we waiting for? So I'll get right to it, and I think I'm going to skip very quickly through the first few points because I'm preaching to the choir in terms of whether it's the right thing to do. I think I want to address three questions here today. How strong is the rationale to scale up to universal coverage? I think that one has been addressed. I'm not going to spend a lot of time on it. Can we afford to put more people on treatment? And then what should we focus on in terms of priorities going forward? I think everyone is familiar with the HPTN 052 study indicating that ART reduces the risk of transmission of HIV. And we now have plenty of data that starting ART is also in the best interest of patients. That really brings us now to the question of, can we afford to do what's clearly the right thing to do? At first glance, it looks like a rather daunting challenge. We have 15 million patients on treatment today. Our target is roughly 30 million patients, so a doubling of the number of patients in care. And the question is, does that mean we need twice the level of resources that we have today in order to get there? Just taking a look back, as we've seen from 2008 to 2015, a 3x expansion of HIV treatment and care. It's worth noting that the level of HIV funding has only increased by about 40%, and I'm going to get into the specifics of it, but a lot of those increases are not necessarily being driven by the cost of treating patients. Okay, so how is it that we can afford to scale up at such drastic rates without significantly increasing the overall spend on HIV response? And I think the key is to look at how efficiently we're able to deliver treatment and care to patients and recognize that we are getting more efficient programmatically at delivering care to patients in treatment. So CHI has done some costing work back in 2010 and 11 called the MATCH study, and we've recently refreshed that data. I believe PEPFAR has done their own costing study, and various studies are converging around an answer that in low and lower middle income settings, the cost of delivering quality care to patients is roughly $300 per patient per year, give or take a little. And that's the cost of delivering care from the facility level down, including drugs, diagnostics, and provider costs. So why are we seeing this trend toward increasingly lower cost of care for patients? And I think we can attribute it to three key things which we can expect to continue into the future if we make smart programmatic decisions. Number one, we're starting patients in care when they're healthier, which means that we have fewer healthcare costs associated with treating very sick patients as they enter care. Secondly, simplified models of care and economies of scale are working in our favor. And this includes efforts to task shift, filling facilities up so that they are working at maximum efficiency, and looking at innovative ways to deliver care, such as reducing the frequency of patient visits to clinics and multi-month scripts. Okay, so when you do the math and you look at the roughly $19 billion that's being spent on HIV response today, and you look at what it would cost us to get to reaching the 90 goals, that brings you out to a little bit more than 50% of the currently available funding going to care and treatment of patients. This would leave us room to be smart about our HIV testing and patient identification work, as well as investing in smart prevention programs focusing on biomedically demonstrated methods of preventing new infections. Okay, so I think I want to make a few points about making sure that we continue in the direction on which we are, and it has to do with being smart about what we implement and where we implement it. I think one of the keys is that one size is not going to fit all to get us to the end of the HIV epidemic. And just as an example, I give a comparison of costs in two HIV diagnosis and treatment initiation programs using the same approach, but one being implemented in a high prevalence catchment and one in a low prevalence catchment. And clearly we can see that a program that is cost efficient and makes a lot of sense in one place is not necessarily the correct solution to implement globally. I think we need to be very careful about being smart about what we implement and where to make sure that, as mentioned, those costs per patient treated are really staying as efficient as possible. So I want to shift a little bit and talk about what we need to focus on in terms of delivering efficient quality HIV care going forward. And I want to do that by looking at the cascade of diagnosis and treatment to make a few points. So if we start with all of the people in the world living with HIV, we've expended a significant amount of resource to test a large number of them and diagnose them. But we know that as we go through the process of linking those patients to care and initiating them on ART, we are losing huge numbers of individuals from the care continuum. And if you then continue on and look at how many of those patients are actually virally suppressed, which is the real result we're after here, then you can look at these resources in a bit of a different way. And I would argue that the money and time we're spending on getting a partial result but not getting the full result of a patient whose virus is suppressed is wasting patients' lives, patients' time, and valuable resources that we could be using to get better results. So I think we need to look at and recognize where our spending is being effective and where there are resources that we can more effectively use to get more patients to the point of viral suppression. I think we also need to recognize that this missed opportunity zone that's out there may not have very well quantified costs that are associated with it, but the fact that we don't have great measurements of it does not mean that those costs aren't out there. There is a significant cost to not treating patients that's not only borne by the HIV components of health budgets, and we need to factor that into our math as we go forward. So I think as we continue to go forward, we also, if we want to get to 90-90-90 globally, we not only have to look at programs which are doing very well and are closing in on accomplishing or recognizing those results, but also look at high-burden countries which are lagging behind. And I know I've been to a lot of conferences where we talk about a number of countries which are really in need of some additional help in their HIV response. And I think we really need to get creative and smart about how we work to 90-90, not just in the countries that are getting close and able to, but countries who are struggling as well. So I think we have clear answers to our questions. The rationale for scaling up is clear. I firmly believe we can afford to maintain patients in treatment as care as long as we are not losing them and constantly having to refine and reinitiate them. And so we need to really focus our priorities on being efficient on the spending that we are doing outside of treatment, and in particular, being smart about how we test and find individuals who are not in treatment and care. Second, I think, while a lot of the story of HIV treatment access over the past 15 years has been on cost and accessibility of treatment, as we look forward, I think that will still be important, but a huge part of the efficiency question is going to be around retaining patients in care and making sure patients who we're treating are actually virally suppressed. And I think if you think about resources we devote to a result that is less than viral suppression as a waste, that is where we're going to make efficiency gains. And finally, we really do need to surge in some of the countries who are lagging behind. All right, thank you.